Hello and good afternoon. Welcome to today's NDARC webinar, the first one of 2023. We're very pleased you could join us. I'm very pleased to be your host today. My name is Dr. Sarah Farnback and I'm a research fellow and program lead at NDARC. So before we get started, I just want to take a moment to show my respect and to acknowledge the traditional custodians of the land where I'm dialing in from, and elders past and present. I'm calling in today from Ngambri and Ngunnawal country, and today's webinar is hosted on Gadigal land. So welcome to everyone from wherever you're joining us today. Before we get started, I'm just going to tackle some of the housekeeping and go through how today's session will run. Today we have the good fortune of being joined by one of NDARC's rising stars, Dr. Tom Santo Jr, who's recently had his PhD awarded. Congratulations, Tom. And we'll speak today about his research around the impact of childhood trauma and mental disorders amongst people with opioid dependence. Tom's going to talk us through the evidence on childhood trauma and mental disorders amongst this group, including some of his own research, and he will also make some recommendations about future directions for the field. Tom is now a postdoctoral research fellow at NDARC, and he's a key member of our team. Tom has research experience in a range of methods, including meta-analyses and systematic reviews and other areas. So after Tom has finished, we'll be joined for a panel discussion by Professor Shane Dark, who will reflect on the presentation. We'll also have a moment to go through and address any questions that you might have, so we can have a bit of a discussion after the presentation before we wrap up at about 3. So this is the important bit. If you've got any questions for the Q&A session, please use the Q&A function, not the comment function on Zoom. That way that we'll be able to address them when we get to the end of the session. Okay, I think enough from me. So I'll hand over to Tom now. Tom, would you like to join us and turn on your camera?
Yep.
Hi, Tom, how's it going?
Good, how are you?
Good, thanks. All right, over to you.
Awesome. So I guess that means you can hear me all right as well. So hi, everyone. My name's Tom Santo. I'm a postdoc research fellow at NDARC who recently finished my PhD. I would first like to acknowledge the Gadigal people, who are the traditional custodians of the land on which I'm presenting today. And I would also like to pay my respects to elders, both past and present, and extend that respect to other Aboriginal and Torres Strait Island people here today. So before we get started, I just wanted to go over the fact that in the webinar, I do talk about topics related to childhood trauma, mental disorders, as well as drug dependence. And so we have some resources that we've listed here that are related to that. And I believe Morgane will be sharing these within the chat. And if you feel that you need to reach out for further support, please reach out to these resources. Very happy to have you leave prior to the webinar. Thank you. So today we'll go over a study that was recently published in Drug and Alcohol Dependence. We'll go over some background as far as childhood trauma and mental disorders, as well as some of the problems among people with opioid dependence. We'll look at some of the gaps within the literature, as well as the aims for the current study and how we tried to fill those gaps. We'll also go over the methodology, as this is quite a project that went over quite a number of years. And so we will review a bit of that and then go over the analysis results and conclusions. Okay, so first, funding and conflicts of interest. The funders played no role as far as the current study. Okay, so for some background, people with opioid dependence, as many of you know, are at high risk of harms, including mortality. People with opioid dependence are about 10 times the risk of mortality compared to the general population. And here it's played as a review by Sarah Larney on the different types of mortality issues among people with opioid dependence. Risk of overdose, as well as contact with the criminal justice system, which is an outcome that we'll go over today as well, are also major problems among people with opioid dependence. And so we know that opioid agonist treatment is an effective treatment for people with opioid dependence. It reduces the risk of mortality by about half, and it reduces across a number of different causes of death, including overdose and different harms, as well as contact with the criminal justice system, and also risk of HIV, as well as hepatitis C. So initiating people on opioid agonist treatment if they do have a diagnosis of opioid dependence, as well as retaining them within opioid agonist treatment is definitely a key goal among people, among treatment providers for people with opioid dependence. Apologies. So we also know, just taking a step back, that childhood trauma is frequently reported among people with opioid dependence. It got slightly cut off there, but the first two factors listed there are sexual abuse for both men and women with opioid dependence. And so we can see here that the rates of opioid dependence are far higher among people with opioid dependence compared to the general population. And this goes across a range of different types of childhood trauma. We also know that childhood trauma increases a range of adverse outcomes among the general population. So crime, risk of mortality in adults with or without opioid dependence. We know that childhood trauma increases harm. So we know a lot about among general population that childhood trauma increases these factors. And we also know that opioid dependence is strongly associated with childhood trauma when we look at general population studies. We also know that comorbid mental disorders, which we can see here in the red, are people with opioid dependence. And people in here in the blue, we have the general population. They're also very common among people with opioid dependence. We understand that the prevalence is far higher among this population. And we also know that there are certain harms that are associated with mental disorders among the general population, such as suicide, risk of incarceration, or contact with the criminal justice system. And among people with opioid dependence, like with childhood trauma, we have some cross-sectional studies that show harms that are higher among the group of people with opioid dependence. So we're looking at opioid dependence alone, and specifically that population. We know in some cross-sectional studies that childhood trauma and mental disorders are associated with some harm. However, there are very few studies that have looked at childhood trauma and mental disorders among people with opioid dependence, and then examined if these factors over a long-term period are associated with risk of adverse outcomes. So we know that mortality is a very important outcome to try and reduce among people with opioid dependence, as well as contact with the criminal justice system. And we also know that we would like to increase initiation and retention of opioid agonist treatment among people with opioid dependence. But we've had these two important factors, childhood trauma and mental disorders, and where we don't know exactly how these two risk factors that are very common among this population affect these long-term important outcomes. So there have been some studies, as I've mentioned, that have done some cross-sectional work, and many of them have not been able to look at factors such as mortality, difficult in a cross-sectional study, as well as risk of like previously reported overdose, where childhood trauma was associated with an increased risk. But we haven't had longitudinal studies that have been able to do that. And the final problem, I guess, with the previous literature, although the studies, many of them are methodologically rigorous and have informed how we've done this study, they've only used administrative data to look at the association between mental disorders, for example, and retention and opioid agonist treatment. And although these studies are very useful, the issue that we encounter with them is that only people who receive treatment are going to be captured within the mental disorders arm of this study. So administrative data would be potentially looking at something like the MBS or PBS and seeing if someone received a prescription for a certain mental disorder, or whether or not they received a service for a certain mental disorder. And we know that people with opioid dependence may be disadvantaged in these areas as far as their access to mental health treatment. So using survey data, which is what we did in the current study, is going to capture, I guess, a truer prevalence of mental disorders as well as childhood trauma, which, as we know there, the administrative sources there are not going to pick up everyone who's experienced childhood trauma. So we'll go a little bit more into that in a moment. But as far as the outcomes in the current study, we're looking at engagement with OAT. So we want to see if childhood trauma and mental disorders, whether or not over a long-term period, they affect someone's risk or likelihood of engagement with OAT, or their risk of dropout from OAT. So we're among a large group of people with opioid dependence, were those who experienced more or less childhood trauma, and those who had certain mental disorders at a higher risk of leaving treatment or a higher risk of not initiating treatment over a long-term period. We also wanted to examine if childhood trauma over this follow-up period was associated with risk of a charge for a criminal offense. And we looked at this for both any offense and then violent offenses. And finally, over this period, we wanted to look at risk of mortality. So whether or not a person had died within the follow-up of the current study. So how we were able to do that was in 2004 to 2008 for the comorbidity and trauma study, otherwise known as CATS. There were baseline surveys of about 1,500 people with opioid dependence over this 4-year period. And so we, during this period, looked at a range of questions on childhood trauma. So we looked at different types of abuse, neglect, whether or not people had been bullied often, as well as witnessing parental violence. And we also looked at DSM-4 mental and substance use disorders. So we fully used a survey to assess among this population of about 1,500 people who were receiving opioid agonist treatment, whether or not they had certain mental disorders and certain comorbid substance use disorders. So we looked at this at that specific time point. We also asked during this period whether at what age these disorders potentially were onset, and we also asked at the age of childhood trauma when that occurred. So after we also collected individual identifiers during the initial surveys and sought consent from participants to link their data to administrative data through a de-identified process in which we sent the identifiers to the different administrative databases. They were able to link participants from the CAT study, so about 1,500 people, to all the opioid agonist treatment episodes within New South Wales. So we had the first episode of an individual as well as how often they received treatment over time up until 2014. We also were able to identify if they were charged with any offense during the period from 2004 to 2017, and that includes violent offenses as well. And finally, we matched it to the Australian National Death Index, and so we were able to identify if people had passed away during the follow-up period. And so we were able to successfully match most of the people who most of the participants who were originally surveyed in the 2004 to 2008 period. And as I mentioned, all of the people were receiving or had received opioid agonist treatment. It was a requirement for recruitment into the study. We also identified about 4,500 charges, and that equated to about half the participants who had one or more offense. And finally, 166 deaths were recorded over the follow-up period from 2004 to 2014. And again, just to reiterate, this was done through the identified process where we sent the identifiers to the 3 administrative databases, and then the survey data was linked. So this first figure here shows the amount of childhood trauma that we were able to, I guess, identify from the original surveys that were conducted during the 2004 to 2008 surveys. And how we defined them was by using a latent class analysis. And I know this could be a little bit confusing to look at, but bear with me here for just a moment. The orange line looks at latent class analysis, sorry. It's a person-centered methodology that is used to identify subgroups of people within a larger group. And so you are able to plug into a number of factors. So in this case, 7 different types of childhood abuse, and you see how they group together. And then in this case, we're able to look at childhood trauma, not just from whether or not someone had experienced a certain type of sexual abuse, or try to put this on a scale where you're counting the number of, say, types of abuse up to 10, and just scoring it, but you're able to look at how things cluster together among a larger group. And what latent class analysis allowed us to do here was identify 4 different groups of people who experienced different types of childhood trauma. So you can see the orange line is a group that experienced high forms of all types of childhood trauma. So, for example, if we look at the emotional abuse rates among this sample, it was near 100%. And then we also identified a group in red here that experienced high physical and emotional abuse and neglect, but far lower rates of sexual abuse. The blue line identified a group that was highest on the sexual abuse scales, and the green line finally experienced low childhood trauma pretty much across all types. Obviously, witnessing parental violence is still quite high, but if you remember, we are looking at a group of people that are more susceptible to experience higher rates of trauma. So to look at how many people fell into each group, we had 40% or just under 40% in the low abuse but some neglect range, which means that more than half of the sample fell into one of these 3 groups on the bottom rows of the chart. So the group that experienced high physical and emotional abuse or neglect, or the group that experienced high sexual abuse and moderate parental violence. And then almost a quarter of the group experienced extensive childhood trauma. So this again reiterates kind of what went back into the introduction about the high experiences and high likelihood of experiencing trauma among people with opioid dependence. As far as the mental disorders go and the exposure within this group, again, far higher than numbers you would see amongst the general population. And again, these mental disorders were assessed through a survey at baseline from 2004 to 2008. And then that data was linked onwards to the criminal offenses, as well as opioid agonist treatment and mortality. So we'll go over that in a moment, but we'll just pause for a moment to take some water and allow you to look at this lens. Okay, so our first outcome was time from opioid dependence onset. So the time which was assessed through the baseline interviews from when opioid dependence onset for an individual according to DSM criteria. And then that time frame, we then looked at how long it took for them to enter their first treatment episode. So how long was it from when opioid dependence onset and they started feeling symptoms or started reporting symptoms through this survey? And then when was their first episode of OAT, which we were able to identify through the administrative data. So how long from opioid dependence to treatment? And what we found here was that extensive childhood trauma, as well as antisocial personality disorder and comorbid substance dependence were associated with a much slower transition to treatment. So it took far longer for this group to go from opioid dependence to their first treatment episode. And when we adjusted for age, sex, and education, as well as all the other factors that I just talked about. So we also adjusted for childhood trauma and mental disorders in the analysis. We still found that childhood trauma was associated with a slower transition to the first treatment episode. And we also found this for ASPD and comorbid substance dependence. One of the findings that I found was quite unexpected was that depression was actually associated, even after we adjusted for everything, with a faster transition to the first treatment episode. And so we could talk about some of the implications for that a bit later, but we first will go into the retention part of the study. So as far as retention goes, so this goes for the entire period of follow-up, and we looked at how often people continued to go to treatment after that first episode, which I just talked about. And we found that panic disorder, borderline personality disorder, PTSD, and comorbid substance dependence were associated with less time in OAT. So more likely to drop out from OAT after you go to your first episode. And this, as we know, there's a cycles that occurred with OAT where people drop in and drop out. But when we're looking at the whole time period over a few years, we found that retention was far lower. When we accounted for the dropouts and re-entering treatment and all that, we found that panic disorder, borderline, PTSD, and comorbid substance dependence, they all increase the likelihood that someone would leave treatment and potentially for an extended period of time. And after we adjusted for certain factors, all of them remained except for PTSD. So in adjusted analyses, all these factors were still associated with less retention in OAT. So as far as the risk of being charged with a criminal offense, so we found that antisocial personality disorder, as well as comorbid substance dependence, PTSD, and extensive childhood trauma, they were all associated with the risk of being charged with any criminal offense over the follow-up period. Comorbid substance dependence was the only one that remained in adjusted analyses. And another finding that I found somewhat surprising was that violent criminal offenses or charges for a violent criminal offense was far higher among the group that had experienced extensive childhood trauma. And again, this was after adjusting for antisocial personality disorder, comorbid substance dependence, extensive age, sex, and education. And so that association still remained with the risk of one or more charge. And we used Poisson regressions for this as well as the OAT retention part. So it's essentially a counting type of analysis where we're able to account for not only were you charged with one offense, but had you been charged with multiple offenses and looked over that for the whole study period and accounted for a period of time as well. Finally, we did not find any associations between childhood trauma and mental disorders and mortality. I hesitate to, I guess, say that this has definitively says anything about mental disorders and mortality, because there has been one other study using administrative data that's looked at this, and I believe they did find an association by Morin et al. Using a data from a Canadian group. And I do believe our power highly limited the study. So one of the advantages of using an administrative study that uses only people who receive treatment for mental disorders is that your population tends to be far larger. So you're able to capture a far larger population of people with opioid dependence to include in your study. And unfortunately, you're also more likely to account for a higher number of deaths, which allows you to have more statistical power in the analyses. And I guess the other limitation that could be associated with this, as well as some of the other outcomes, would have to be that the advantage of doing the baseline surveys and assessing for childhood trauma and mental disorders, then mental disorders that were, say, to onset at a later date, we weren't able to capture those as well. So a number of factors could relate to this, but I do believe further research in this area is definitely necessary. So overall, just to summarize, our findings suggest that childhood trauma and mental disorders increase risk over a range of adverse treatment outcomes, as well as social outcomes among people with opioid dependence. So we found that extensive childhood trauma was associated with a slower transition to treatment. And we also found that it was associated with a higher risk of a violent offense. And as far as the mental disorders overall, we found that mental disorders across a range of outcomes, so borderline personality for lower rates of retention, as well as increased risk of crime. And I can go through the various number of mental disorders, but I will save everyone with the reading those all off. As far as the large associations, we found a consistent association with comorbid substance dependence and risk of crime, as well as lower retention in OAT. And it also was associated with a lower risk of or a slower transition to treatment, first treatment episode. And we also found that antisocial personality disorder, as well as borderline too, was associated off a number of those outcomes as well, including slower transition to treatment and risk of being charged with a criminal offense. So we hope that these results can assist mental health and opioid dependence treatment providers as far as transitioning to treatment and breaking down certain silos, which I'll talk about in just a moment. But for example, the transition from the first opioid dependence potential diagnosis to the first treatment episode, or the certain signs that someone may show of opioid dependence, certain factors may be not necessarily indicative of that, but may slow someone's transition to treatment. And hopefully, if someone is receiving care for their mental health issue or potentially a trauma-related issue in the past, that if they are also experiencing problems with opioid dependence, we're able to get them treatment for both comorbid issues more quickly. So potentially mental health providers either referring their clients who also have issues with opioid dependence to opioid dependence treatment providers, as well as them working together in potentially an integrated care format, would certainly help reduce some of the harm that we're seeing among this population. We'd also say that incorporating different types of policy, understanding this in different types of policy decisions. So that may relate to crime, as well as policies that are related to the availability of OAT. And we know that Natasha Kasev, one of my supervisors, has done a study on OAT retention and how stable periods of OAT we are reduce the risk of harm of crime. Understanding that these factors not only affect the risk of crime, but also are associated with OAT. It stresses the complexity of the issue, but it also emphasizes the importance of providing trauma-informed care and also providing mental health treatment for people with opioid dependence, and ensuring that people have access to both treatments for these comorbid issues that we see overlapping so often. So again, I guess just to reiterate, the availability of trauma-informed care and informing research centers on how to, or not research centers, apologies, clinical settings on how to integrate trauma-informed care, as well as understanding that many of the clients that will present to places that may give treatment for opioid dependence are very likely to see a high amount of trauma within their clientele. It's extremely important to, I guess, educate staff, as well as just be understanding that this increases risk of a number of different harms and may affect the course of someone's experience with opioid dependence, whether it be their initiation into opioid use or the long-term effects that are related to more potentially more risk, higher risk of contact with the criminal justice system, or different factors that will potentially impede opioid dependence treatment, but also could be something that is addressed during opioid dependence treatment to try to put an integrated care model into place and potentially treat comorbid issues that are affecting why people leave treatment at certain times, or why they are more likely to have contact with the criminal justice system. So understanding that these factors may affect a range of different things related to opioid dependence. And finally, understanding the barriers to the different treatments that we understand are relevant to both care for trauma as well as care for mental disorders. So stigma and privacy concerns may be something that's very relevant for people who've experienced trauma, as well as those who've experienced opioid dependence. And understanding how we can be sensitive to these issues, which includes things like trauma-informed care. I believe there's a statistic that shows that people in substance use treatment are far less likely to return if they do reveal experience of trauma and it's not listened to. I think it seems quite obvious, but it can really affect both things. So understanding this, and then also integrating trauma-informed care in a way that's actively addressing something that we understand is so highly prevalent in this population is important. So if we can remove or reduce some of these silos, I believe that we can, or not I believe, but there certainly could be more people that are able to access mental disorder care as well as opioid dependence treatment. And so again, just to end off, I'd like to thank my supervisors, Lisa Degenhart, Gab Campbell, and Natasha Kasev, as well as Elliot Nelson, who is on this paper as well. And a big thank you to those who were involved with the CAT study, their interviewers, as well as the participants, number one, for sharing their experiences. And my social media and email is there if anyone would like to ask further questions. I know there was a lot gone over today, and I appreciate you taking the time to listen. And again, I'm very happy to answer questions today or offline. So thank you.
Thanks, Tom, and congratulations. That's a fantastic presentation. You've really given us a really good run through. Oh, that's good to my letter. Really nice run through the area and some of the research. So just before I open up for some questions, I'd just like to properly introduce Professor Shane Dark, who's joining us today. Really needs no introduction, but Shane has worked with us here at NDARC for over 30 years. He's a world leader in research around opioid dependence and illicit drug use. So welcome, Shane. Thanks for joining us. I'll just start by maybe inviting you to, did you have any reflections or anything you wanted to comment on before we head to the audience for questions?
Yeah, of course. Firstly, I'd just like to say, Tom, that's a great body of work. And I don't think audience, when you present something like that in half an hour, it doesn't give the flavour of the sheer thousands of hours of work that went into it. And the importance of that is what you've done is collates provide really solid estimates of the size of a problem. And I think there's two things. So I got 3 quick points. Firstly, what these data and other studies have shown that people presenting to treatment are complex cases. Anyone walking in the door for opioid treatment is very unlikely to just have opioid dependence as a problem. There are, as you say, high levels of abuse, and I think we should always remember neglect as well, which you did. And obviously what you see then are very high levels of mental health problems. Now, this is probably not news to anyone who treats people in the sense that I think from the treatment perspective, people need to be aware that issues such as child abuse are going to be frequent and they are going to come up. And I think that from awareness from the broader public and funders, that the sheer burden of disease that people that are treating people with opioid dependence are dealing with. And I think that comes down to then recognition of what the sort of resources and training that our drug treatment centres need to answer complex problems. I think the second point I think is the fact, Tom, that you were able to look at how this actually affects the trajectories of, and these aren't just like histories of abuse. It's not just historical facts. It's affecting people now. It's right. Affecting and the mental health. It's affecting, as you said, time to seek treatment. And of course, we all know the early treatment's good treatment. So the longer it's the more difficult the problems become. That the mental health issues will affect those outcomes. So this is not just like, oh, that's terrible what happened. It's affecting people now. Mm-hmm. Now, as you point out, I think there's both need to be addressed, and this comes back to training, etc., and providing the appropriate resources. And I refused. I'll have to utter it, but silos. I've been listening to about silos since 1988. Although we had a speaker last year that referred to them as palaces, which I thought was good. And we did have a speaker last year talking about cooperation between drug services and mental health departments, case management. And of course, the problem, these cases fall across both, and that integration, I know we've been talking about it for decades, but it is absolutely crucial. And I think then also that what this tells us is that these are complex problems that you have to have realistic expectations of outcomes. There are no quick fixes to complex problems. And so we can't expect someone to go into treatment of these complex problems and suddenly be fine within months. It's unlikely, possible, but unlikely. And we need to realise that it's actually, we found in things like our study of the Australian treatment outcome study, the longitudinal study of heroin users, long-term stable treatment is what is associated with the best outcomes, and providing those psychosocial interventions with it. But I think one thing, we should never give up hope. We've just completed our 20-year follow-up from the ATOS sample, and 3/4 were currently abstinent. And every single one was a daily user in 2001 of that. So, and, you know, people cycle in and out, but, you know, I think sometimes you can remember your failures, not your successes. And just finally, everything that you've said about OST also applies to the other major treatment modality, residential rehab. People walking into resi rehabs have these sorts of problems exactly the same, and people cross between the various modalities, and we find the same thing. Long-term stable retention is important. So I thank you for the work, for showing up these, I think, important clinical issues.
Thank you. Yeah, as far as the original purpose of recruitment for the participants, it was not necessarily to look at the childhood trauma and mental disorders over a long-term period. So as far as only including people with opioid agonist treatment experience or that were receiving OAT at the time, it wasn't a particular design of the study. And as you noted, these problems are, I think we would certainly expect them across a range of different settings that provide treatment for people with opioid dependence and probably different substance dependence use as well. Yeah.
That's great, Tom. Yeah, and I think you've spoken nicely to some of the you know, areas that are coming up in this sort of field around trauma-informed care, and really acknowledging that across the system as well, not just within particular services. So I know that's something that you're interested in and we're all working on as well. Great. So we've got a few questions, so I might just try and tackle a couple. Firstly, the first question that came up was, could we just maybe have a brief description of opioid agonist treatment? A couple of other attendees have helpfully provided some links for us, but maybe if perhaps Tom or Shane, you could just briefly talk us through what that actually looks like, just to provide some context for us.
Well, it looks potentially different in Australia than the rest of the world, but it's receiving either methadone or buprenorphine, which are agonists or partial agonists of the same receptors, I guess, that heroin binds to. And so it relieves some of the withdrawal symptoms that someone would get when they were stopping heroin use, and also goes to decreasing the likelihood that someone would reinitiate injecting heroin use. Shane, there's a more complex way to explain it, but yeah.
Yeah, I don't think we need a more complex one. It's as it says, it's basically giving a long-acting substitute to reduce craving and substance use. And what we do find consistently is that the rates of heroin and indeed other drug use goes down, and mental health improves, physical health improves, and we often forget about physical comorbidities. There's a lot of disease like liver disease, etc. And I think probably most importantly above all, mortality goes down. So it's often said, what you're giving an opioid to someone who's opioid dependent, to which I think the answer is yes. And why? Because we know it's an effective treatment.
That's great. Thanks, guys. Just good to make sure we're all on the same page, talking about the same thing. So a couple of questions just on your studies, Tom. One of the questions is around, the likelihood, I guess, of people reporting their experiences of sexual abuse, and just wondering if you had any thoughts about if it's likely or not that some participants might have experienced abuse but not necessarily reported it into the study.
Yeah, I'm sure that's probably the case for a lot of, well, the rates that we're seeing were quite astoundingly high, but I don't doubt that there were certainly some participants that probably felt discomfort with disclosure. But it's the rates overall, I think it was about a core. I'll have to look that up again, but yeah, the rates were quite high overall. I mean, far higher than anything you would see in the general population. This study actually started as a matched control study. And so there was controls that had different characteristics that were similar to the people who were receiving opioid agonist treatment, and far higher among that group as well. So we're still quite astoundingly high. But yes, I don't doubt that.
Yeah, sure. Thanks. A similar question here from Jennifer. She's sort of asking about whether you thought that access to treatment or, access to the services, I guess, that provide OAT might have impacted on the findings. Can you talk a little bit about the setting or where the CAPS participants were actually recruited from, and whether you think access might have affected it?
So I guess they were recruited from the 34 of the 35 sites within Sydney, so 30 of the private or public OAT clinics within Sydney, but it certainly could have affected whether or not they went from the first from opioid dependence onset to their first OAT episode. And I don't doubt that that may have something to do with the trauma association. So we found that extensive childhood trauma decreased the participants who'd experienced extensive childhood trauma had a slower transition to their first treatment episode. And I don't doubt that they probably had far less of a support system potentially, or far less of access, whether it be by their area. Access can mean a range of things for different people, whether it be financial barriers or physical. But we know that, for example, rates of childhood trauma in areas that may have less access to treatment, there's associations there. So it depends on how we're talking about access, but it certainly would have affected some of the findings.
Great, thanks. So the next question here was from an anonymous attendee. Did you know how many were repeat offenders with their charges when you were looking at the administrative box of data?
Yeah, I believe it was 20%, but that was for any offense charges. And then for violent offense charges, I'm not exactly sure of that one. Could find it though.
We're asking you to recount your detailed findings from your PhD.
Yeah,
off the top of your head.
yeah.
No worries, thanks. And so the next question here from Anna is about, did you collect any information on the time of exposure to childhood trauma, frequency of exposure as well?
Yeah, so unfortunately, we do have some of that data. But it was quite difficult to incorporate it, given how so it wasn't incorporated into the definition of the variables. So, for example, bullying was only included if it was often. So we asked about whether people were bullied, but that's why I noted bully often there, is because we did measure it from a frequency standpoint as well. As far as time of exposure, trying to combine 7 variables of different types of childhood trauma, which were made up from about like 15 to 10 different items for each category. It gets quite messy on how we define that. So there is some data on it, and it was incorporated into some of the variables, but we weren't able to incorporate it on how we analyze the overall 7 items. Yeah. But it is important. And we know that like frequent sexual abuse, for example, is associated with a range of adverse outcomes related to mental health and suicide risk as well. So yeah, there's certainly associations that we've seen in other studies and other populations. Yeah.
Thanks, Tom. So this next one comes back to, I guess the experience of people accessing treatment, and it's from Stacey, and she's talking about high staff turnover often at services. And she said a lot of clients have said to her that, I hope you stay working here because nobody does. And, she's wondering if you have had any thoughts about whether this might affect the ability that they have to develop trust and relationships with the, clinicians and the clinical providers. Did you have any thoughts about that, either of you?
Well, I think it's a very good point. And it's about building a therapeutic relationship with someone, and that's true of any clinical interaction. And I suppose what it reflects there is, I think, the sheer stress upon staff, and I think you go to any treatment agency in this country, and what they'll say is they could do with more resources. And I think Tom raised the point in his wrap up too about wellness, of staff wellness, and supporting staff support, which I think is important. And I know we've had some, it's also been coming more difficult. There are some work's come out of this centre on prescribers. It's getting more difficult to get prescribers. So I think it's a very important point.
Yeah, I think across the board, as far as being trauma informed, it's a large area as far as what it covers. But part of that is understanding that your staff may have had traumatic experience as well, and it may be related to the work too, as far as potentially experiencing the loss of someone that they were close with, if they were having a frequent interaction with them. And then also, Shane, what you mentioned as far as long-term stable treatment too, being able to, it falls into that issue too, as far as changing of providers and not being like building a trustful relationship over a long period of time, where you're able to, share these experiences and address them. It is difficult, and hopefully we can increase resources, I would say, to provide more for staff who are experiencing taking on some of these issues and also experiencing their own as well.
I think it also just shows what you're saying. The maximum respect deserved to people who are work in the treatment field. Do a magnificent job. Yeah, Sarah's gone.
Sorry, I just lost connection for a minute. But I think can you hear me okay?
Were we boring you, Sarah?
Something like that, Shane.
Yeah.
Sorry, everything just, that moment, everything just went blank, but I'm back. Thanks. So I've got a question here from Catherine. From Catherine for Tom and Shane. Oh, it's just a bit. So just asking you to comment on, did you have an impression of the role of buprenorphine in chronic and complex trauma group, and whether it provides OAT at an adequate level of consistency and intensity for this group of patients? So a question there for both of you to talk to, because I know Shane might have some thoughts on this one too.
Yeah, well, I can't answer about this particular study, and I doubt if Tom could. I'm not sure.
No one in this, because the OAT data ended before. I think it was, they would have, no one in the group would have been able. I mean, they could potentially be on it now, but.
But I think the issue that being raised there is actually right on the money. For people who don't know, buprenorphine basically is that you have a long-acting buprenorphine that you don't have to go back. I can't remember. Is it 1 month? I can't remember offhand. There are various formulations. So rather than going in, for instance, with methadone daily or seeing your providers daily, you might, for instance, have this slow release inserted under the skin, and there are advantages to that. You don't have to go in the clinic every day. You know, it's easier to hold down a job, etc. But I think what the question is getting at, you've got a high, it's not going to suit everybody. So people with, there are a lot of people who really need that clinical interaction, and perhaps it's about matching who's going to benefit and who actually might have unintended negative consequences by being isolated. They're being maintained, but not maintained on the opioid, but not getting that psychosocial support that might be very crucial for people with high rates of mental health and problems and distress.
Absolutely. Especially potentially that maybe somewhere they're getting access to mental health treatment, maybe things, so like the contact may be beneficial for some people, but also you know, it also may allow them to go elsewhere if they're, yeah, it really is individual.
But I suppose what you're saying, that's a good point. But saying if you want to make sure that someone that you're worried about has some sort of support, whether that's a psychologist, social worker, whatever, even if it's not in the clinic per se. But there are great advantages in mobility, etc. But I think what we've learned over the years is that one size doesn't fit all, and that it's a complex cases with different presentations and different solutions that are needed.
Yeah, sure. Thanks. I mean, I think that this question follows on quite nicely. There's a question here from Anik who's said, would it be possible, you know, did either of you have any thoughts about, you know, future research or work that might work with or look into children of patients with childhood trauma to investigate the intergenerational trauma and any role that might play? Could be through interactions with child protective services or other services.
Yes, I sometimes it does get a little bit difficult, unfortunately, with the amount that's captured. I think if you look at like the general population studies, or even the administrative data that use like the child protective services among people with opioid dependence, and then we look at like the surveys of the same group, you know, we capture so little of it, unfortunately, but it still could be something that is looked at, certainly. And to how parental substance use, as well as mental disorders, as well as their own experiences of trauma, affect people long term, and as well as their children.
Yeah, well, I think as a general cry of the heart, longitudinal research is always worth it. Sometimes it's very hard to explain to funding bodies why, but given everything we know about the social determinants of substance use and problems such as we've been discussing today, the suggestion of the questionnaire is sensible. Whether one could get funded, that's always the question, but that's true for any research.
Yeah, thanks.
I think we could all relate to that.
That's right. Lots to do, right? None of us are without work to do. That's great. Thank you. So I've got a couple of minutes left. So I think we've got one final question that I'll try and squeeze in, and we've got through most of the questions today. So the final one here is from Pauline, and she's asking, is there a difference in the impact of trauma between clients who are on OAT after using illicit opioids versus those who are on OAT subsequent to pain management with opioids?
I would guess that, so I'll speak to, I guess, this study first, that most likely the majority of clients that we received from this study, I believe, were primarily using heroin. Given the way in which they were recruited, I think most of them would have been primarily using heroin first, but there's also another study that I did for my PhD, which looked at the risk of opioid dependence among people who were prescribed opioids for chronic non-cancer pain. And we found that childhood trauma was a strong risk factor, again, after we controlled for a range of different mental disorders, age, sex, and some of the other factors that you would consider high risk for opioid dependence. Extensive childhood trauma, again, was associated with risk of opioid dependence or risk of harm. In this case, you're looking at a population of people prescribed opioids. So we, again, know that trauma among this population is also higher than the general population. As far as comparing between the two groups, in our review, we did not have enough data, unfortunately, among the people who were prescribed opioids for chronic non-cancer pain. So definitely an area to explore and have further research in, particularly given the growing number of people with opioid dependence who primarily use pharmaceutical opioids. But yeah, it's certainly an issue that spans different populations or subpopulations of people with opioid dependence.
Thanks, Tom. Can't answer every question, every research question with every study, right?
I think I tried on this one. Yeah, 3 different outcomes. Yeah. But
that's great. So Shane, did you want to just add anything, or Tom, did you want to add anything just before we wrap up?
I'll just throw in quickly, just in relation to Tom's life, and I know it's. I think we also should keep in mind, that may be out of fashion, but the concept of self-medication. It's that the high levels of distress and abuse and opioid users at least suggest that it's that at least some cases may well be self-medicating distressing affect. I can't prove that, but I think it's something that we should bear in mind.
If I would say, the importance of initiating treatment for potential adolescents with opioid dependence, especially given that the age that we saw opioid dependence onset, and the lack of research among adolescents, particularly in the US, where we know that it's a growing issue. Understanding that the population, or again, early treatment is better, and understanding access is a little bit more difficult among this population is important.
Yeah, excellent, great, and that's a great spot for us to finish. So thank you very much for a fantastic presentation and a really interesting discussion, both to Tom and to Shane. What a great start to the year. It's a great way to finish off today's presentation.
Thanks everyone for listening.
Yeah, thank you. Before we wrap, I just want to point to the next couple of seminars which are coming up over the next few weeks. Can you believe it's the end of February already? So next week we're lucky enough to have with us Professor Mal McLeod, who's going to be presenting on the CanTest drug checking service. The following week we've got Dr. Jalal Gamali presenting on opioid use in Iran, and that will be followed by Dr. Emily Deans, who's going to be presenting on a qualitative study that she's done that involves young offenders around drug and alcohol. So that's a wrap for us. Thanks so much for joining us, and we look forward to seeing you again next week. Have a good afternoon, everyone.
Thank you everyone. Thanks, Shane. Thanks, Sarah.